This morning's headline in the largest newspaper in the state of Maine says this: Portland Falmouth officials deliver bleak report on opioid crisis. It's getting worse. And this headline disturbed me greatly because I feel there's been so much focus on the opioid problem, the epidemic that is tearing apart our communities and costing the lives of so many. We've passed legislation, we've increased funding, we recognize that you have to focus on education and prevention, law enforcement, treatment and recovery, and yet we seem not to be making the kind of progress that we need to make. Already, for the first 6 months in the state of Maine, 185 people died from overdose. That means that if that number remains stable, we're going to have a very similar death rate, 376 deaths, that we did last year. The CDC has put out my favorite chart, which shows that for every one overdose death, we have an enormous problem underneath. So my question to each of you is, what more do we need to do? Why are the efforts that everybody is making and working so hard not working?
I'll just briefly comment, Senator. I appreciate the question. I think that one of the places where FDA can have an outsized impact, and we all have different roles to play, is on trying to reduce the rate of new addiction by taking steps to decrease the overall rate of exposure to opioids. We know this comes down to math. A certain percentage of patients who are exposed to opioids will become addicted, and the key to reducing the rate of new addiction is to reduce overall exposure. We're going to do that by changing, first and foremost, changing prescribing behaviors among physicians. Most people, as I mentioned, who become addicted will become medically addicted. They'll move on. Oftentimes, they'll be for an immediate release formulation of a drug, Vicodin and Percocet. They'll move on to higher dose formulations and eventually the low-cost alternative, which is street drugs. And so we've taken steps in recent months to increase provider education, for example, around immediate release formulation drugs. We're looking at steps we can take to try to limit dispensing. I mentioned the FR notice we put out recently asking for comments in the public around this. And we're also looking at what we can do with respect to mandatory education. But I think the key is, for us, is going to be to try to reduce overall exposure.
I think you're absolutely right that we have to put more effort at the front end of this problem and reduce access by changing prescribing habits, and particularly by allowing partial fills, by allowing physicians, by training physicians that they should only give 10 pills, not 50, that sort of thing. Dr. Collins, do you have anything to add?
So totally agree with what my colleague Scott just said, but I also want to say we really need to push then into the space of having alternatives to opioids for those 25 million people who do suffer daily from chronic pain. We can't leave them hanging with nothing to help them. And what they have right now is not helping a lot of them with chronic pain, where opioids are really not the appropriate treatment. And yet we do not at the present time have great alternatives. So certainly from NIH's perspective, putting our foot on the accelerator, working with industry in an unprecedented way to try to cut into half the time that it takes to develop that next generation of non-addictive but highly effective pain medicines is something that we now want to see happen. We're currently spending about $116 million a year on opioid use. We think that needs to be greatly increased by a factor of 4 or 5, and together with industry, we could do something here to speed up this process of coming up with better alternatives.
Thank you. Dr. Howe.
Hi. I would add that I think in Washington, it's been one of the states that's really integrated their prescription drug monitoring programs with their ER records, and they've seen a lot of proactive reporting. So we're preventing those people on that pyramid from getting addicted. It's identified people that are taking high dose, morphine doses, and then sending alerts to physicians so they know to then intervene and consider tapering that patient off. And the flip side too, I'd say, is to really do more with surveillance. We just started in Maine our syndromic surveillance, where we're using what we use with bioterrorism, where you look at EMS or emergency department data to look at new trends. And this is how Maine and many other states here on this panel are being able to detect new community outbreaks. We did that in Georgia, and we picked up 5 overdoses from the fake Percocet pills. And so now you know where in communities to intervene more quickly.
Thank you. Dr. McCants-Katz.
Yes, and so I agree with everything that my colleagues have said, but I'm also going to say that we still do not have adequate access to treatment, to evidence-based treatment for people who need it. And so as long as that situation occurs, we're going to continue to have the terrible kinds of tragedies that are the opiate epidemic. We need more specialty care. We need integration of addiction treatment into primary care. We need to use our certified community behavioral health centers to provide addiction treatment. We need to educate practitioners starting at the undergraduate level, medical school, nurse practitioner school, physician assistant school. Everybody, this is just my view, should come out being eligible, having gotten the education to get that data waiver. And they need more than classroom experience. They need practical experience. In the state that I come from, Rhode Island, we had started a program where clinicians could come to our centers of excellence to get that practical experience, to give them the confidence to provide that care in their communities. So we need to be doing all of these things.
Thank you.